Thank you all for your testimony. Madam Chair, do you have any questions?
I do, but I'm waiting to get an answer back from my staff if they're not in a meeting as to how much we've spent between the DOD and the VA trying to get their medical records straight. So,
too much.
I'm going to wait. Too much, but million.
Yeah, that was one of the biggest surprises I had when it was on MilCon was how much we spend on VA, and we still not get it right between the service and the VA.
Should I put you on the spot and ask you the number?
It was
too much.
A term ago, yes. But I was on it.
I think we could spend a fraction of the cost getting BIA medical records up. But I'm gonna wait until after you, Mr. Simpson, are done. Thank you.
Mr. Simpson?
Thank you all for being here and for your testimony. Instead of trying to find a way to keep things funded during a government shutdown, what we ought to commit to is that we're not going to shut down the damn government anymore. Bad policy, bad politics, just stupid. I don't think you'd find any argument from anybody on this committee or anybody on the Appropriations Committee that's no way to run a railroad. But I understand your issue and your problems, and it seems like we always forget about, when we're over the years when we've done certain things for certain agencies to prevent things, we always forget to include Native Americans in it and stuff. So that is a problem. Just out of curiosity, Sonia said that you had 22,000 patients throughout Santa Clara County, right? And you had 70,000 patients that come from surrounding community and so forth.
Yes.
Are those all Native Americans?
Yes.
Do you serve anybody outside the Native American population?
Yes. I'm also a federally qualified health center, so I serve everybody.
Okay. And the reason I ask that is right now they're having an issue in the Idaho legislature between they're trying to expand dental care to allow dental therapists on Native American reservations, which the Dental Association is okay with. Mm-hmm. The problem is that if they then serve also non-Native populations, that creates a problem of expanding the scope of practice. And that's the challenge they're kind of dealing with right now. There are only 2 states that allow dental therapy, one of them Minnesota and one of them Alaska. And I've always taken the position I don't want the federal government determining what scope of practice is. That's the state's responsibility. Yeah. And so they're trying to work that out. And I have no problem with allowing dental therapists on reservations to serve Native populations, particularly in areas where you can't get a dentist to go.
Right. There's so many rural communities, and access is critical. And recruitment has always been an issue, whether it's tribal or urban. So we continue to face that across the board with all providers.
And that's the challenge is serving the Native American population versus the non-Native American population by the same therapist,
Right.
So they'll work it out, but it's good that they're discussing it. But thank you all for being here today and for your testimony.
Thank you.
Do you have a question? I have one.
I have one for Mr. LeBeau. Under former Chairman Calvert's leadership, the subcommittee provided significant funds to the Indian Healthcare Improvement Fund to try and reduce the funding disparities across Indian country. Did those funds considerably improve the situation for California tribes?
Well, not in the way that we had hoped, given that there's over 100 federally recognized tribes in California and, well over 50 tribal satellite clinics in rural and frontier regions of California. The end result of the first distribution of funding to the California IHS area resulted at about 3 to 4 small tribal clinics receiving some funding. For those particular clinics, that's great news, in terms of, continuing to deliver care. But for the vast majority of tribal clinics in California, they saw zero funding during the first go-round. I happen to serve on the IHS Indian Health Care Improvement Fund work group representing California, along with a gentleman by the name of Chris Devers from Southern California. We continue to advocate and make recommendations to the full work group and to IHS to strive to ensure that more resources are provided to chronically underfunded IHS areas. The issue continues to persist, however. So we do appreciate the support of the committee in providing funding for that line item. It was helpful. additional support and direction and guidance, I think, from committee would be even further helpful. Thank you.
Thank you, Madam Chair.
Thank you, Mr. Joyce. Current contract for VA going out 10 years is an additional $16 billion. My staff has said, he told me he was going to try to pull together how much the government spent in the last 20 years. I told him this was good enough to make our point. Thank you. I think we need to get better. We heard last year about challenges with medical records in general. Some systems, I think in California, we're still using DOS. If I heard it was not very efficient, not very practical, and not right. I would like for a second the special diabetes program. The doctor mentioned, and almost every tribe when it comes to health care talks about it, has been flat funded since 2004, and the amount of dollars that it saves by preventing cost overruns in Medicare, Medicaid, any of the federal programs that tribal members might be eligible for, plus the Indian Health Services. Is there a repository someplace so that we know how many people are not being served by this program because we've not increased funding? Do you know if that's available either through the National Congress of American Indians or any of the health boards? Because I think that would be helpful in us in making the debate that we should look at increasing those funds, because it's going to save lives. It's going to improve the quality of life, but sometimes the argument that we need to have is it's going to save tax dollars with our fellow colleagues. Do you know if that's available? And if so, would you maybe see if you could get it to us?
Sure. So the section of the testimony that I provided was a result of the work of the National Indian Health Board, where they're calling for $200 million to fund the special diabetes program for Indians. NIHB does note that treatment of end-stage renal disease costs. It's about $90,000 per patient per year. So there's a reduction in the cases of end-stage renal disease that translates into significant cost savings for Medicare, IHS, and third-party payers. In addition, the program has proven itself effective, especially in declining incidence of diabetes-related kidney disease in particular. The incidence, again, of end-stage renal disease due to diabetes in Native Americans has fallen by 54%, a greater decline than for any other racial or ethnic group. And so that detail is derived from the National Indian Health Board. And I know we have representatives from NIHB here today. We'd be glad to provide you a full report on that particular issue if you would like.
Thank you to my colleague for acknowledging NIHB's work in this space. And we always talk about SDPI being the most successful public health and prevention program. Special diabetes for, right. And acknowledging that its success is based on the for the tribes, by the tribes, and each tribe being able to design their unique program around their community's needs. And I think you raised an important point on the data that we need to continue to collect, and NIHB stands positioned, and it sounds like an amazing pilot project that we'd love to participate in, so that we can ask our funders and our appropriators to continue to fund and increase this program to save dollars in the end. And we always say that IHS would rather cut off a limb than prevent it, and that's just devastating and sad. And why is that the level of care that we're providing to our First Nations people?
Thank you, Mr. Joyce. I think that we're looking at how we're reducing the cost of the disease as it progresses, but the one thing we probably won't be able to quantify is when someone starts changing the way they're preparing food at home, everyone is impacted by it. So we actually might see a decrease in diabetes in the future. So I think making sure that you have the tools to collect the information would be helpful. And with that, I yield back, and maybe Mr. Simpson would like to introduce the next panel.
That's okay. Go ahead.
He didn't want to do it.
He didn't want to do it.
But I certainly appreciate it. As my sister's a juvenile diabetic, and having watched it all my life, I can appreciate the work that goes into it. So I'm with you on whatever we can do. And thank you all for your testimony and being here today.
Thank you. And these are for members of the committee.
Thank you so much. So I noticed Victoria's listed here twice.
Sorry, it's too far to reach for me.
Selected that they're going to speak on it. She's going to speak about the unit.
Okay, that's fine.
Thank you all for your time. I appreciate it.
Victoria, you can just stay up here. Okay. Hey, good to see you.
The other thing we tried to do was the loan thing and scholarship money to grow.
The workforce, yeah. I highlighted that quite a bit. And they've got some, that intern program that we were talking about.
This is kind of shaped like an arrowhead,
If you want to move in a little closer, if it's easier for you.
It's hard to surprise Joyce here.
You slip over one more than you had the mic to yourself.
Yeah. You got a twin sister, don't you? That was just here.
How'd you work in another 5 minutes? I know. Just kidding.
So I welcome with great honor the chairman of the Fond du Lac Band of the Superior Chippewa, the council member from Bad River, Great Lakes Superior Chippewa, and once again a tribal council member from Winnebago Tribe of Nebraska. And if we could ask the chairman of Fond du Lac to lead off the panel. Thank you, sir, for being here. Good to see you again.